Hello everyone, I am Dr. Jyoti Verma. In this class, we will be discussing cardioversion versus defibrillation. Both use electrical energy to restore normal sinus rhythm, but they are applied in a very different clinical context. As anesthetists and physicians, it's crucial to not just know how to deliver a shock, but when, why, and which type of shock to choose. In this class, we will discuss the similarities and the differences between the two and the practical aspects associated with them. Let's get started. Cardioversion and defibrillation. Cardioversion is used to terminate arrhythmias. Arrhythmias such as atrial fibrillation, atrial flutter, avian reentry tachycardias, or hemodynamically stable ventricular tachycardias. It is a synchronized shock. What is the meaning of synchronized shock? Synchronized means that it gives shock at a particular time of the cardiac cycle. It gives the shock at QRS interval during the R wave. So that is why it is known as synchronized. During the shock, it depolarizes the excitable tissue, making the tissue refractory. When the tissue becomes refractory, it is not able to propagate or sustain any arrhythmia or re-entry and retains normal sinus rhythm. Sync detects patient's R wave. When the patient's R wave is detected, there are R wave markers. As seen in this ECG, there are R wave markers which detect the R wave. And when the shock button is pressed and held, the button is pressed and held, it discharges shock with the next detected R wave. So, as first it detects the patient's R wave, and when the shock button is pressed and held, it discharges the shock with the next detected R wave. So, as it gives shock at a particular time, that is why it is known as synchronized shock. In this image, you can see that there are markers for R wave with the arrow. These arrow have detected the R wave and will give shock at R wave only. If we talk about defibrillation, defibrillation is a treatment for life-threatening arrhythmias. What are the life-threatening arrhythmias? Ventricular fibrillation, pulseless ventricular tachycardias, and since they are life-threatening, they have to be treated ASAP. But cardioversion is planned, and defibrillation has to be done ASAP. So, shock applied by defibrillation also depolarizes the critical mass of heart muscle. It terminates arrhythmias, making the muscle refractory and allows normal sinus rhythm. It can be delivered by external defibrillators, by transvenous defibrillators, and by implanted cardiac defibrillators. It can be monophasic and biphasic. Monophasic current flows in single direction. In biphasic, current flows from the negative electrode to the positive electrode and then reverses back. Current flows from the negative electrode to the positive electrode and then reverses back. This bidirectional flow of current leads to lower energy requirement. It is safe and there are less chances of burns. After introduction, we will go with the indications of cardioversion and defibrillation. If we talk about cardioversion, tachyarrhythmias causing hemodynamic compromise to the patient such as conscious ventricular tachycardia, supraventricular tachycardia, atrial fibrillation, atrial flutter, atrial tachycardia and junctional tachycardias can be treated with cardioversion. For defibrillation, the rhythms are life-threatening rhythms such as ventricular fibrillation or unconscious VT. They have to be done ASAP. Life-saving. Then we'll discuss the contraindications. So, cardioversion is not to be done in ventricular fibrillation, unconscious VT, and if the patient is on digoxin therapy, the energy required should be lowered. If we talk about contraindications of defibrillation are, if the patient is DNR, patient has chosen do not resuscitate, and if the patient has rhythm of non-shockable rhythm, such as patient is in asystole, patient is in pulseless electrical activity or bradyarrhythmias, patient is having supraventricular tachycardia or stable or conscious VT. So after discussing indications and contraindications of cardioversion and defibrillation, we will discuss the equipments required. So the equipment required are same for both of them. So we require a defibrillator, we require pads for giving shock. They can be adult size and pediatric size, both should be available. Then emergency trolley or crash cart should be available with emergency drugs. IV access should be there. We have to be ready for intubation and suction should be present. If cardioversion has to be done, sedation has to be given to the patient. So sedative agents are required for cardioversion. After equipments, how to do a procedure. First, we will discuss cardioversion. So, as the patient is relatively stable in cardioversion, and we have to explain the procedure to the patient and take consent. Consent has to be taken for cardioversion. After consent, then we will sedate the patient with sedation agents and we will attach ECG electrodes of the defib machine. ECG electrodes of the defib machine has to be attached behind shoulders and away from the placement of pads. Then, as this is a planned procedure, we have to be very careful and we have to follow each step. Skin has to be prepared. There should be no air pockets. The defib pads, the pad should be away from the ICD, pacemaker, IV line, ECG electrodes. Then, position of the pads. For cardioversion, they can be placed antero-posteriorly or antero-anteriorly. So if we talk about antero-posteriorly, it is placed in the mid-clavicular line at fourth intercostal space on the left side and posteriorly also on the left side under scapula. So this is the image of antero-posteriorly. This is placed just anterior to the heart and then posterior to the heart. Both are placed on the left side of the patient. This is placed on the mid-clavicular line, fourth intercostal space, and this is placed under the scapula left side. So this is the antero-posterior position. And then if we talk about antero-anterior, the placement is like this. You all must have seen this placement. On the right side, it is on the second intercostal space, and on the left side, it is just at the apex, mid-axillary line, sixth intercostal space. So, what is the preferable position? The preferable position of pads is antero-posterior. So, after placement of pads, we will turn the dial to defibrillation and press the sync button with holding it. Holding the sync button is really important as it will detect the R wave and then deliver the shock. So, sync button is pressed and held. Then we can see the R wave markers on the ECG. If we are not able to see the R wave markers on ECG while pressing the sync button, then we need to increase the ECG amplitude. We need to increase the size of ECG and see for the R wave markers. After this, we will select the energy. Energy is variable, can be selected depending upon the rhythm of the patient and condition of the patient. So we can start with 50 to 100 joules and then we can upgrade if needed. So after selecting the energy, we will charge the machine, defib machine. While charging, after it gets charged, there will be an audible alarm that the pads are charged. Then we have to announce I clear, you clear, everyone clear. Everyone should be away from the patient trolley and then the shock is delivered. After delivery of shock, we have to observe the rhythm and again continue the algorithm as per guidelines. So, we have to just remember that we have to stand clear and deliver the shock and then observe the algorithm. So, for defibrillation, sedation is very important, which is a difference between defibrillation and cardioversion. For cardioversion, sedation is very important. It is a planned procedure. We have to give sedation to the patient. We have to take consent from the patient and apply pads. Skin preparation is very important, and then we have to see for R wave markers on the ECG and press and held the sync button. We have to press and hold the sync button such that it detects the next R wave and delivers the shock. We have to stand clear and then observe the rhythm and do accordingly. If we talk about defibrillation, defibrillation needs to be done ASAP, as I've discussed earlier. It improves the survival of the patient. As soon as we do it, there are more and more chances of patient's survival. So, the area where pads are to be placed has to be clean and shaved. There should be least of the impedance for maximum output. So, the impedance can be provided by the body mass, temperature, sweating, water, or quality of contact. So we have to keep in mind all these things. Then we have to attach the pads to the defibrillator. We have to attach the ECG electrodes of the defib machine. After attaching pads, as we have discussed, pads on the left side is mid-axillary line, 6th intercostal space, and on the right side is parasternal, 2nd intercostal space. After attaching them, if the patient has ICD or pacemaker, the pad should be placed 8 cm away from the device. In order to avoid interference of the shock, we have to place the pads 8 cm away from the device. There should be no IV line, electrodes or drug patches under the pads. There should be no drug patches such as buprenorphine. There should not be any electrode, ECG electrode or IV line between the pads, and there should not be any air pocket, and pads are not repositionable. It's not like we can remove them and reposition them again. So we have to be careful while placing them for the first time. Then we have to turn the dial to defibrillator. We have to select energy. Usually depends on the rhythm. 200 joules is selected. Then we have to charge. As the machine is charged, it will give an audible alarm, and then we have to stand clear. We have to make sure that everyone is clear. We have to announce like I clear, you clear, everyone clear, and then deliver the shock by pressing the button, and we have to observe the ECG rhythm and continue the algorithm as per the rhythm. So, this was the procedure of cardioversion and defibrillation. What precautions have to be taken? Precautions are, we have to check for the expiry dates of the pads. We have to avoid, patient should not be wearing any jewelry, patient should not be wet, there should not be any water on its body parts. Patient's limb should not be touching the bed railing, and we have to replace pads every 24 hours or after 50 defibrillations. There should be minimum interruption to CPR, and the flow of oxygen should be away from the patient's chest. It could lead to spark. We have to avoid flow of oxygen towards the pads. We have to make sure that the oxygen is away from the patient's chest. We have to check for the motor response to shock. When we deliver the shock, when we press the buttons, there should be a motor response to the shock. Else we have to check for the battery or lead fracture. We have to see skin for burns. So, after these precautions, if we are unsuccessful, we have to see for the 5H and 5Ts which are there in the ACLS protocol, which are 5HR: hypoxia, hypovolemia, hypothermia. We have to see hyperkalemia, increase or decrease in potassium. and we have to see for H plus ions increase or decrease. So these are the 5H, and then 5T, we all know that they are tension pneumothorax. We have to rule out tension pneumothorax, we have to rule out toxins, we have to rule out coronary thrombosis, we have to rule out pulmonary thrombosis, and we have to rule out cardiac tamponade. So we have to see 5H and 5T, and we have to ensure that the pads are placed uh, right in a right position, and they are changed if they are expired. We have to ensure that the machine is charged and is able to charge and is able to deliver shock, and the battery is at of optimal level. So this was a basic idea of defibrillation and cardioversion. If you like this video, please give it a like, share and subscribe. Thank you so much.